Reactive attachment disorder is a psychological disorder that causes the individual with the disorder to have emotional and behavioral issues. RAD symptoms will usually appear before the child is 5 years old. This disorder is caused when an infant fails to form a healthy attachment to a primary caregiver. When the infant fails to attach properly or the attachment is broken, it can lead to devastating consequences. Children with RAD will usually present it in two different subtypes: RAD inhibited withdrawn type, which is children who withdraw from interpersonal encounters, and RAD disinhibited indiscriminate type, which is children who show little inhibitions when it comes to strangers, are impulsive as well as non-selective in who they form relationships with. A child with RAD will not turn to a familiar caregiver in times of distress. They do not seem to use their primary caregiver as their safe base to explore their surroundings. They will also withdraw from interpersonal encounters and are reluctant to interact with their parent figure. John Bowlby was a psychoanalyst who believed that mental health and behavioral problems could be linked to a person's childhood. Bowlby believed that humans came into the world biologically imprinted to form attachment with other human beings to survive. He believed that attachment behaviors are instinctive and will be activated by conditions that threaten the desired proximity, such as separation, insecurity, and fear. Bowlby suggested that a child's fear of strangers was a survival mechanism that is built into humans at birth. Babies will display certain behaviors, also known as social releasers, that will help them ensure close proximity and contact with their primary caregiver. The social releasers include smiling, crying, crawling, and reaching toward their caregiver. Bowlby believed that an infant would form one main attachment, usually with the mother, and the attachment figure would be a security base for the infant to explore their surroundings. This attachment would serve as a prototype for all future social relationships. If this attachment process is interrupted, it would have dire consequences for the infant. The first main point of Bowlby's theory of attachment was that a child was born with a need to attach to a primary caregiver. Bowlby preferred this to be the mother, but believed that another primary caregiver could be an adequate attachment figure for an infant. His main belief was that there needed to be some sort of primary bond that was more important than other relationships for a child to be successful in surviving. The second main point of Bowlby's theory of attachment was that a child should receive continuous care from a primary caregiver for about the first 2 years of the child's life. Bowlby believed that the first year of the child's life was very critical for attachment. The loss of a mother or a primary caregiver is just as detrimental as never having bonded with a primary caregiver at all. Bowlby even believed that a child who is routinely separated from their mother for even short periods of time, that the child can have long-term cognitive, social, and emotional problems later in life. This included mothers going to work and leaving their children in daycare. Bowlby's third main point of the attachment theory was that there are long-term consequences for children who fail to bond with a primary caregiver. Bowlby believed that the consequences could include delinquency, reduced intelligence, increased aggression, depression, and psychopathy. If the person has psychopathy, they will have an inability to show any sort of concern or affection for others. The fourth main point of Bowlby's theory of attachment is that even a short-term separation from the primary caregiver can lead to distress. Bowlby found three stages of distress, known as the PDD model. Protest, where the child will cry and scream and protest angrily when the parent leaves. Despair, the child's protesting begins to stop and they will appear to be calm even though they are still upset. And detachment, if the separation continues, the child will start to engage with other people again. The fifth main point of Bowlby's theory of attachment is that the child's attachment to a primary caregiver will lead to a development of an internal working model. The internal working model is a cognitive framework that represents understanding of the world, of oneself, and of one's understanding of others. Mary Ainsworth collaborated with and expanded on John Bowlby's attachment theory. Ainsworth performed a study called Strange Situation Test. She performed this test to see the development of infant-mother attachment during the first year of the infant's life. The infants were placed into categories A, B, and C according to the pattern of behavior they had shown during the strange situation. The test consisted of the mother leaving the room and then returning. Ainsworth studied the infant's reaction to being separated from the mother and then being reunited with the mother. Babies in Group A rarely cried when they were separated from their mothers. When their mothers returned, they barely made contact with them, and they even ignored their mothers. Babies in Group B would use their mothers as a secure base to explore their surroundings. When they were separated from their mothers, they were usually distressed and would stop exploring their surroundings. When their mothers returned, they would seek close contact with their mothers. Babies in Group C showed some anxiety before their mothers had even left the room. When they were separated from their mothers, they were in great distress. But when their mothers returned, they would tend to stay close to their mothers but would avoid contact with them if possible. Causes of RAD can include physical abuse, sexual abuse, neglect, failure to bond with a primary caregiver. If the infant spent early life in an orphanage, the primary caregiver was mentally retarded. The primary caregiver lacked proper parenting skills and did not comfort infant or show infant enough attention, or the primary caregiver didn't meet the infant's basic needs for food, play, and hygiene. Any child can be at risk for RAD. Those with increased risk include children who have been placed in foster care, children who have been adopted out of an orphanage overseas, children who have been adopted out of foster care, children of alcoholic parents, children whose parents has a mental illness, a child who has been physically, mentally, or sexually abused, any child who lacked a consistent primary caregiver, and a child whose parent is in prison or elsewhere. Not every child who has these risk factors will develop RAD. Symptoms of RAD in an infant and young child can include, but is not limited to, problems eating. A child with RAD may have trouble bottle feeding, often choking on the milk or formula. The child may also be a very picky eater. This can lead to a lack of weight gain. The infant or young child may even cry a lot and may be difficult to comfort. Other symptoms include severe colic, unresponsive behavior, inappropriate closeness or familiarity with others. Older children and teenagers with RAD most likely will want to spend most of their time alone, want nothing to do with their caregiver, be difficult to comfort, most likely will not want to be touched, they will resist social interactions, or will think it is perfectly acceptable to socialize with complete strangers. Children and teenagers with RAD may even have unhealthy eating habits, most likely due to the abuse and neglect they had suffered. They may hoard food, hide food from others, gorge themselves, and eat items with no nutritional value, such as flour and other items. The teenager may begin to show even more of a lack of impulse control and empathy to others. Those with RAD may begin to have severe mood swings, temper tantrums, issues with depression, and issues paying attention. In extreme cases, an older child may also engage in criminal behavior such as stealing, destruction of property, violence toward others, and cruelty towards animals, but show no signs of regret or remorse from their actions. One technique that is used to treat RAD is a therapeutic process that attempts to stimulate the regulation process that would be found in a healthy infant-parent relationship. This will usually involve the child who has RAD to work through a traumatic experience that happened to them, with a focus on maintaining psychological homeostasis through the completion of the process. The parent will have been counseled on ways to remain completely attuned to the child's emotional function. They will seek to regulate these high states of arousal. The hope is that over time the child will learn to self-regulate and will begin to build trust in the caregiver. Integrated play therapy is considered to be highly effective in treating children with RAD, especially those who are living with adoptive or foster families. A form of integrated play therapy, called TheraPlay, is usually recommended for these families. In TheraPlay, the therapist will take a directive role in facilitating attachment through structured play. Holding therapy, also known as rebirthing therapy, reduction therapy, and attachment therapy, was designed to repair the broken relationship between the parent and child by recreating the initial infant birthing experience of establishing trust and attachment with a primary caregiver. Holding therapy states that symptomatic behaviors of RAD are the result of the anger the child has repressed. Holding therapy is not recommended because it may actually increase aggression in children with RAD and may serve as a mechanism that causes the child to relive the trauma they have already experienced and can make them worse. Some professionals claim to have had great success with holding therapy, but many more professionals claim that it is dangerous and detrimental to the child. The American Academy of Child and Adolescent Psychiatry issued a statement that said holding therapy was not an effective form of therapy and cited instances where children have actually died during the holding therapy process. The deaths have actually led to many states outlawing the practice of holding therapy. It is very important that counseling professionals study the child's behavior and symptoms in depth before diagnosing the child with reactive attachment disorder. Just because the child has a background of neglect or abuse does not mean their behavioral issues are the result of RAD. It is also important that professionals keep up with the current research concerning reactive attachment disorder, as well as engage in research that will help to further the evidence of effective treatments. Research needs to explore the causes, implications, and treatments for reactive attachment disorders. It is my belief that if more professionals working with children in the foster care system and in orphanages are made aware of reactive attachment disorder, what causes it, what it is, and how it can be prevented, there is a chance that reactive attachment disorder diagnoses will decrease.